coming academic in the summer too. So we're just going to go ahead and get started and jump right in. Lilia has a lab updates, and then after those, we will go into our research presentation, which we're leaving the bulk of time for today because it's the results from the Ivy Lab's first randomized controlled trial. So we're just excited to be able to share those results with you guys tonight and get feedback as we are incorporating them into submission for peer reviewed articles. Okay, Lilia, well, I'll let you get started.
Okay. So first off, we had some acceptances to ACOG this year, which is so exciting. So, one of our M2s, Victoria, she got her abstract accepted to ACOG, and then so did Carrie. She's a resident that works with us. And we also had an acceptance to ASAM, and these are some students that work with Michelle on the SORT study. And their names are Susie and Hannah. And we also had we had a group of our students from the Castle project submit their abstract to ASAM, which we will be sharing more about their project a little bit later on. And we also had some submissions to SASCOG. So Ellen and Taylor also submitted to SASCOG. And here is, let me see if I can send the Zoom link in the chat for anyone who's interested. But the Writing Center is hosting a presentation on common trials and design for anyone who is interested. And I know these flyers are super small because I had to fit them on my slides. So if you are interested and I haven't sent these to you already, please feel free to email me and I can send you the larger copies of them. But there are some undergraduate research opportunities coming up with the Translational Writing Center. And then there's also a VCU Summer Fellowship. And then there's one more on the other slide. And then there's also the Undergraduate Research Creative Scholarship Summer Fellowship. So if you are an undergrad interested in research, please email me and I can send you these if I haven't already, so you can learn more about them. Okay, now getting into our research updates. So Brenna, a fourth year medical student that works with the lab, she just got her manuscript accepted. And then this is a paper that we submitted that got accepted a few months ago, but it finally got published. So we're able to share a screenshot of it. Okay, and we have quite a few manuscripts in review right now. AB has three manuscripts in review, and then Dr. Martin has 2 manuscripts in review, and Gus has a manuscript in review. And we had some recently accepted manuscripts. As I said, Brenna's manuscript was accepted. Dr. Martin had a manuscript accepted, and then Shivanya also had a manuscript accepted. And here is some promotion. Some social media promotion. We are on Twitter. If you're interested in following us, our handle is Ivy Labs 9. And we also have a YouTube channel. So if you can't get enough of these meetings and you want to watch more, we post our meetings on YouTube, or if you miss out on one and you want to catch up, feel free to find us here. And I do believe that our handle is the same on YouTube as it is on Twitter. Okay, now getting into some study updates. So, Project Better is the randomized control trial that's going to be presented about today. So, recruitment is complete on this study, and follow ups are still ongoing. There were a total of 37 participants, and this study provides a theoretical grounded assessment of feasibility and acceptability of a new technologically delivered educational intervention for pregnant and parenting people receiving medication for opioid use disorder. And Anna Beth is the lead coordinator of this study. And next we have Project Sort, which recruitment is complete for Sort. Chart reviews are ongoing, and this study has a total of 211 participants. And this study is investigating the relationship between sleep and opioid use disorder recovery. And Michelle leads this project. And then the other project we have going on is the registry. And this is an ongoing record to track clinical outcomes of our pregnant and postpartum patients who seek addiction treatment with OB Motivate Clinic. And there are 133 participants involved, and AB and I co-lead this project. Oops. Okay. And this study is postpartum recovery, which is a prospective cohort of 26 participants, and follow-ups have been complete and chart reviews have been complete, but we still do some secondary analysis with this. And this project compares biopsychosocial factors such as pain, mood, impulsivity, and maternal infant attachment captured during the 3rd trimester of pregnancy and within the 6 weeks postpartum. And this project is run by AB. And then we have Project Castle, which is currently in progress. We're still building the study currently, but it is an intervention, a computerized intervention that educates medical professionals and pre-medical professionals on substance use disorder stigma. And I lead this project. And if you are one of our M1s who is interested in joining us for the summer Dean's funding this summer, we will have an office hours to inquire and interview each of you on January 25th from 2 to 3 p.m. And if you are interested in attending, please send me an email. My email is on the left side. Okay. And I will send you the invite prior. And then also next lab meeting is to be determined. We will send out the invite as soon as we get it scheduled. And then here's my email if you have any questions, updates, or if you want to contact me about any of those research opportunities that I spoke about earlier.
Thank you, Lilia. We always have a lot of updates when we take off a little time for the holidays. So congratulations to everyone who had a paper published or accepted or abstract. We've had a lot. We're really excited for the conference season coming up and people preparing to represent the Ivy Lab at lots of different places. It's always an exciting time. And also the completion of recruitment for multiple studies, which also coincided around the same time, also very exciting, as we are in the fun data analysis, interpretation, and writing stage for a lot of our projects in the lab. So we're going to go ahead and move on to the research presentation. If you have any questions about anything Lilia went over, please send her an email, including if you are one of the M1s who's interested in applying for the summer funding. We do have up to 3 spots that we can take our lab this summer. So we are excited to meet you and talk to you and see who can join our lab coming up. So I'm going to hand things over to Anna Beth, who's going to do our research presentation today. Anna Beth, before you get started, just for people who are newer to the lab, if you can just tell us a little bit about who you are, your journey, your academic journey, how you ended up working with us, and what are your next steps. Like an interview. It's like an
I
interview.
know that's a lot to include. I will
Yeah.
first apologize. My dog is barking. My child is expressing lots of feelings, so there might be a lot of noise in the background. But we'll see. I'm Anna Beth. I am a 7th year in the clinical psychology doctoral program. So I've been here a while. I first started working with Dr. Martin in 2019. So also been in the Ivy lab for a while on lots of projects. I've been interested in the kind of intersection of addiction and women's health for a long time. So Dr. Martin's lab was the perfect fit for me. And let's see what else. I am applying to internship right now. So in our program, we have to do a 1-year internship before we can graduate. And so I just finished my last interview yesterday, and we'll find out where I'm going in mid-February. So more soon about where I'm going. Did that answer all your questions? I don't remember.
Yeah.
Yeah.
That was good. That was good.
Okay. Um, so I'm gonna go ahead and share my screen. There is a lot with this study, and so Dr. Martin and Lily, if you can if I'm still going at like 10 minutes left, just let me know and I'll try and speed and wrap up so that there's some time for questions. Um, okay, let's see. Can you all see not the prisoner slides, the regular slides?
Yeah, you're good.
Okay. Um, so like Dr. Martin mentioned, I'm going to be talking today about the randomized feasibility trial. So the first randomized controlled trial in the Ivy lab. But Project Better, as I was working on this presentation, I realized some part of it has been going on since 2019. So for about 4 years. So since we have new people in the lab, I'm going to give a little bit of an overview of how it started and kind of where it originated from, and then kind of where we are now with the study. Okay, so the broader background, I'm not going to spend too much time on because for those of you who have been in the lab, know a lot of our studies come from this kind of same problem. And the people who are new will hear this multiple times throughout all of these meetings. But as a broad overview, overdose is a leading cause of pregnancy-associated death, with most deaths occurring in the postpartum period. And even with advancements in opioid use disorder treatment, opioid-related deaths continue to be on the rise, and medication continuation rates decrease rapidly after delivery. So birthing people with opioid use disorder face unique stressors during the postpartum transition that can negatively impact both the patient and their infant, so the parent-infant dyad. And these include things like infant care stress, loss of public insurance, psychiatric comorbidities that are exacerbated postpartum. Could go on a lot about the unique stressors, but those are some of them. And despite provider counseling, birthing people with OUD report feeling overwhelmed by having to manage withdrawal symptoms in their infants, which is known as neonatal opioid withdrawal syndrome. And then also just they're overwhelmed by maintaining their recovery during all of the stresses that come with postpartum. Many birthing people also with opioid use disorder also have a child welfare case opened postpartum, even when they're in treatment, or including the people who are in treatment. And that is a really stressful, really big source of stress for lots of people. Current educational approaches for families with opioid use disorder treatment are insufficient. So methods are needed to support for providers caring for pregnant people with opioid use disorder. And technology delivered interventions can supplement standard care to extend the reach of perinatal opioid use disorder interventions, relieve clinician burden, and improve parent-infant dyad outcomes. So as I was just talking about, you can see this is a systemic problem that really has tangible implications on our patient population at VCU. So in 2019, the Ivy Lab conducted a qualitative study to identify patient and provider reported aspects of the pregnancy to postpartum transition that impacted the recovery process postpartum for people receiving medication for opioid use disorder. And they identified 3 areas of need. So one was the recovery-oriented care strategies for birthing people with opioid use disorder during this transition from pregnancy to postpartum. They also identified an area of needing improvement was guidance around caring for an infant at risk for developing NOWS or neonatal opioid withdrawal syndrome. And then also help preparing to interact with child welfare after delivery. And this was the study that the team published on this one, so you can look this up if you're interested in more about that. And so in response to the problems identified both in the literature as well as clinically here at VCU, Project Better was created. And so Better stands for bringing education through technology, empathetic listening, and research. And there were several aims to the overall project. And so first, it was to develop a tailored, patient-centered, technology-based intervention, as well as a standard practice brochure that could serve as an intervention and a control condition for a randomized controlled trial in the future. Excuse me, but this development phase was an iterative process that occurred over several stages. So the data that I mentioned on the previous slide informed the intervention development, but then we solicited input from experts and used that feedback to revise the intervention. And then we pre-tested it with participants and revised it again. And when the intervention was finalized, then we have used that intervention in the subsequent aims. So then next, the second aim was to conduct a preliminary study to assess the feasibility and acceptability of the intervention in the brochure in the OB Motivate clinic. And the results of this preliminary study suggested that the materials were acceptable for pregnant and postpartum people with opioid use disorder taking medication. And it was also feasible to use in a clinical research setting. And so just to clarify how this was different from what I'm going to talk to you about for the current study, we only had people test one module of the intervention, or if they were interested in looking at others, they could later, but we didn't test it as a full intervention. It was just the different pieces, and it wasn't a randomized trial. It was just, again, testing the pieces of it to get feedback. But this aim provided justification for evaluating the modules as an intervention in the clinical trial that I'm going to talk to you about. And then the final 2 aims were to conduct a randomized feasibility trial using the technology-based intervention and the standard practice control, which was a brochure. And hopefully in the future, we will be able to scale up to a fully powered efficacy randomized control trial to evaluate the impact of the intervention on postpartum parenting efficacy among parenting people with opioid use disorder. And so you can see that we have completed the first 2 aims and published on these, which is exciting. And then we are currently working on disseminating the findings from the trial that I'm going to talk to you about. So that's going to be the focus for the remainder of the talk. Any questions from anyone so far? Speed of the history. Okay, So the current randomized feasibility trial aimed to assess the methodology for a larger efficacy trial, estimate the recruitment and completion rates for a subsequent trial, and to examine the usability and acceptability of Project Better's intervention for pregnant people receiving medication for opioid use disorder within OB Motivate was the perinatal addiction clinic that we used. So again, this was a feasibility trial. Participants were randomized to either receive the technology delivered intervention or standard practice control, which was a brochure that we developed. I'll go over more detail about those in a few minutes. The research assistant screened the OB Motivate schedule weekly to identify patients who are potentially eligible, and then reviewed eligibility with the clinical team and by the medical record review. And then the research assistant approached potential participants with the study about the study during prenatal visits. And patients who were interested in the study confirmed their eligibility and then provided informed consent. So I'll kind of go over this again later in a flow diagram, but the key thing to point out is we were doing this in a clinical setting, working really closely with the clinical team. Participants were adults who were pregnant, and they had to be less than 34 weeks pregnant so that they had time to complete the intervention, ideally. Receiving medication for opioid use disorder could have been methadone or buprenorphine, and then had been engaged in care for less than 10 weeks as a way to kind of standardize who was coming in, who was enrolling in the trial. And then you can see the exclusion criteria, people who were incarcerated, if they were planning adoption, non-English speaking, and if they had any other significant issues that prevented informed consent. Our target sample size was 10 participants for each condition, and that allowed us to have an 80% power. Okay, so I'm going to talk a little bit more about the study conditions. So this is an overview of really both the intervention and the brochure content, but I'll talk about it with the intervention first. So it consists of 3 modules. You can see the postpartum transition, neonatal opioid withdrawal syndrome, and oh, that doesn't say opioid, it should say opioid. And then child welfare. And then they had subtopics for each of these modules. We had everyone start with an introduction so that they could get used to the format. And these were all delivered via a program called SciAS. I can't remember what that stands for off the top of my head, computer authoring system, but it's a really cool program that if you're interested in learning more about, we can talk about that after another time. It allows you to develop modules and interventions or surveys, lots of different things. Okay, so the modules are based on principles of motivational interviewing and are guided by this interactive narrator who we call PD the parrot. He reads questions and speaks tailored content out loud to the participants. So for example, if they there's questions that are asked throughout, and if they give based on their answer that they select, he gives a personalized reflection or a response to their answer. Psychoeducation is delivered by professionally produced videos that we created a while back. And these have providers and also patient testimonials. Each module is designed to be completed in about 20 minutes. And participants are encouraged to complete all 3 modules, but they could complete them in any order that they chose. And they didn't have to complete any of them. Part of this was to see if they would complete any of them, and if so, how many they would complete. So here's an example of some of the postpartum transition module content. You can see there's interactive questions and information from PD and pictures. It's pretty. We have I have links that we can send if people want to test them out. I didn't want to take up time to go through those today, but if you're interested in seeing more of the intervention, we can get you that information. And then here is an example of some of the content from the NOWS module. You can see two of our wonderful pediatric providers, nurse practitioner and pediatrician. And then they're providing information on NOWS. And then this is a more hands-on video, I guess, where they have a mom and a baby, and this nurse is showing her how to do the 5 S's to help take care of her infant with NOWS. Okay, and then this is the brochure. Brochures are commonly used as part of clinical care in OB Motivate. So this isn't unusual. That's why we have it as a standard practice control. The research team developed this brochure. So there's a paper copy and electronic version, and it covered an abbreviated version of the same information in the intervention. And the brochure also has this QR code that you can see that links to a website that was authored by the study team that provides more detail on each of the topics, but it's just reading the information. So it's not near as interactive as the intervention. So for the study, we assessed participants 3 different occasions. So at baseline, which was during pregnancy, and then 2 times 2 follow-up assessments. The first one was during pregnancy, and then another one was postpartum. All participants who completed the baseline assessment could then be randomized. There was a 3-week period for participants to review whichever study materials they were assigned. So either the modules for the intervention or the brochure for the control. And then within 2 weeks of completing this 3-week review period is when we did the first follow-up assessment. And so importantly, this follow-up assessment needed to be prior to delivery. All participants were compensated $20 for completing the assessment. So they're $20 each, up to $60. And at each of these assessments, the components of the assessment were a survey, a brief interview with the research assistant, and then a medical record review by the study team. And throughout the study, the research assistants sent periodic telephone or automated email reminders, depending on which stage the participant was at. And for what I'm talking about tonight, we're only focusing on this first follow-up assessment. You can stay tuned for future secondary analyses that will look at some of the information from the postpartum follow-up. All right, so the outcomes for this RCT were feasibility, acceptability, and usability outcomes. So I'll go over those a bit more. The primary feasibility outcomes were guided by the feasibility typology utilized in the preliminary feasibility study. So the second paper that was on that other study has more, that other slide has more information about this, Sarah Martin's manuscript. But these are broken down into 4 categories. So process assessment, for us, that was recruitment and completion rates. Resource assessment, which was focused on the recruitment time frame, any technology issues, workspace, staffing, compensation issues that came up. The management assessment includes protocol deviations for us, and then, I'll go over the scientific assessment on the next slide. But these three that I just talked about were evaluated with observational data that was just tracked over the course of the study. For the scientific assessment piece, the 4 perceived helpfulness items from the post-treatment attitudes and expectations questionnaire were used. They're measured on a 6-point scale, which you can see here. And we adapted them to assess information that was pertinent to our study. So the bolded parts of this you can see kind of correspond to each of the modules content. So about postpartum recovery, withdrawal in the baby, again, postpartum recovery, and then interacting with child welfare. And so for this, mean scores were calculated and compared by study condition using a t-test. And just of note, this is also the measure that was used in our sample size calculation. All right, and then as part of the project, as part of Project Better is the second aim kind of the overall project. Our team, led by Sarah Martin, developed a acceptability questionnaire. It's called the CARE questionnaire, but it's based on this framework that assesses 7 constructs of acceptability for healthcare interventions. And so this was our primary acceptability outcome for the current randomized controlled trial. It has 11 questions that are all assessed on a 5-point scale with higher scores indicating greater acceptability. And for this, median scores and interquartile ranges are presented by study conditions. So I'll show you that in a little bit. And participants were also asked open-ended questions about their experience with the brochure or the intervention. And then finally, for usability, SciAS tracked module completion and time spent on each module for the intervention participants. And then the RA tracked which participants reviewed the brochure from the control group and the method that they completed that, whether in person or remotely. And then the RA also tracked any technological challenges for either condition. Okay, so moving on to our results. So we had 29 participants that were randomized. On average, they were about 30 years old, primarily white and Black, and most received public insurance. The median estimated gestational age at enrollment was 24 weeks, so during the 2nd trimester. And many of our participants had experienced at least 1 prior birth and had been receiving medication for opioid use disorder most had received it for more than a year. And they were primarily on buprenorphine or receiving buprenorphine, but quite a few also on methadone. We had 1 adverse event. So it was a participant in the control group who did not complete the study. She experienced a medical emergency while pregnant and her fetus did not survive. This was unrelated to the study, but important to note in the feasibility trial. Okay, so this it's really small, but I'll try and point out the key things here. This is our consort diagram, which just shows the flow of participants throughout the course of the study. So we recruited participants from January 2022 through June 2023, so the 17-month recruitment period. And starting at the top, 85 participants were identified as potentially eligible based on the clinic schedule screening. The RA approached 49 of those and confirmed eligibility. 31 provided informed consent. And so we had about a 63% recruitment rate. As you continue to move down, you can see that all of those completed the baseline assessment, and most of them were then randomized. At each stage, these arrows to the side, you can see people were lost for various reasons, but of the eligible people, that's most commonly that they were just lost to follow-up. Right, let's see. The follow-up visits were completed between March 2022 and October 2023. And overall, we had about an 83% completion rate. And you can see the breakdown by condition, study condition here, 81 for the intervention group and close to 85 for the control group. And of note, 2 participants, I think one from each condition, delivered preterm before they completed the follow-up visit, which made them ineligible for that one. So that'll come up again at the end. So just important to note. Okay, so then continuing with our feasibility assessment for the resources assessment, the projected timeframe for the study completion was extended due to slow recruitment. So we recruited about 2 participants per month. So it wasn't as quick as we would have hoped. And then these were just some issues that came up with different resources. So workspaces, obtaining compensation for participants, and then availability of participants. But the primary barrier for recruitment was potentially eligible and enrolled participants missing clinic appointments for recruitment or for continuing in the study. And then we also had a management assessment issue. So 7 participants were inadvertently switched to the opposite treatment group after randomization occurred. So we can talk more about that in the following slides too. For our scientific assessment outcome, the mean perceived helpfulness scores were similar between intervention and standard control groups. So you can see here the mean score on this axis, and this is the score for the intervention group, the score for the control group. And they both approached maximal values, which is a positive thing. Okay, and so these are our acceptability findings, and there's a lot going on this slide. But the key things to point out are this is the constructs are highlighted here in bold for the care questionnaire, and then each of the questions within the construct. And over here you have the medians and interquartile ranges for group 1 is the intervention group, and group 2 is the control group. And so again, the primary thing to point out here is that the scores were high for all of the constructs. So a median of 5 on a scale from 1 to 5, and then 4.5 and 4. This is reverse scored, so lower scores are better. And again, high scores across both groups here. Similarly for these other constructs. And then these are study-specific questions that are added on to the end of the care questionnaire. And these responses were also positive, with participants reporting a preference for receiving the information through either of the study conditions compared to receiving the information from their provider. And then also highlighting the belief that the material would be helpful for other birthing people receiving medication for opioid use disorder. Okay, and then these were the open-ended questions. So you can see the questions listed here on in this column, the condition that the responses are for, key ideas, and then representative quotes. So participants reported liking the intervention and the brochure, liking that they were informative about important topics relevant to pregnant and postpartum people receiving medication. The modules were described as comprehensive, and the brochure was described as a decent outline. So you can see a few differences there. Participants in the intervention group liked the videos. And participants in the intervention group noted that they found this method of education to be less judgmental than the traditional delivery by a provider. Some participants in the intervention group did indicate that they were long and that they didn't like the parrot avatar. Okay, and then so finally for usability for the intervention, about half of the participants completed at least one of the 3 modules, and most of them did so remotely on their own device rather than in the clinic on a tablet. The NOWS module was completed the most, with about a little over half of the participants completing it, and then you can see the other 2 were completed at lower rates. I've also included the range of time that it took generally for participants to complete the modules. So you can see pretty wide range, some completing it less than the 20 minutes that we kind of say that it's designed, but some taking much longer than 20 minutes. Let's see. One participant noted challenges getting all the videos to play, and then another temporarily didn't have access to a smartphone or computer at home, so wasn't able to complete the modules remotely. Let's see. About 3/4 of the participants in the control condition reviewed the brochure, with many of them doing so remotely, and none of them reported any technology difficulties. Okay, so the principal findings for the study are that study recruitment and completion rates were high. We know that pregnant people with opioid use disorder have many demands on their time, and research requests can be burdensome. And so our research team worked really closely with the clinical team to coordinate recruitment and help reduce clinician burden. And also the protocol and the content being informed by formative data from patients and providers in the clinic may have increased willingness to participate. The intervention was perceived to be as helpful as the control. And while this is a null finding, we took this as a win because OB Motivate is resourced to provide comprehensive care to pregnant people with opioid use disorders. And although it's not always provided consistently when prioritizing the demands of clinical care, it is part of standard prenatal counseling. So if we can provide something that is as good as standard care, then that's great. And if we can expand this to be used in general OBGYN clinics that don't have as many resources, we hypothesize that it will be perceived as more helpful than standard care. Let's see. The intervention was preferred to prenatal counseling from a reproductive healthcare provider. Participants highlighted they felt less judged when receiving the information by the intervention, which is particularly important given that these topics are highly sensitive and often very stigmatized. Approximately half of the participants in the intervention condition completed at least one module, which is actually consistent with other studies using remote technology delivered interventions. Even though we offered kind of hybrid options for people to complete them in person or remotely, most people did complete them remotely. But the completion rates were low, so only about a third of the participants completed all 3 of the modules. We designed it this way so people could pick and choose what they wanted to complete and what would be most helpful for them. But we might consider using some kind of incentives for a future study, something like contingency management, while also keeping personalization as an important aspect. Also, the few participants did note disliking the length and the parrot, so they could have discouraged continuing. So there is a new avatar that is offered as part of SciS, and we can work on shortening parts of the intervention. So we can also take those things into account for a future study. But overall, the findings support that Project Better's hybrid intervention is feasible and acceptable for use in a larger efficacy clinical trial. So a few lessons learned from the first randomized control trial in the Ivy Lab. Although we were able to recruit the target sample size in the projected time frame, I think I skipped ahead. Anyways, the projected time frame we had to extend, so including additional study sites would be helpful. We did have the randomization error where people inadvertently got switched to the opposite group. And so we've talked about how increasing study staff oversight and using more automated methods to help prevent this from happening again. Let's see. And then also at least 2 people who delivered preterm were unable to then continue with the follow-up visit. And so we know that preterm birth the prevalence of preterm births is higher in people with opioid use disorder. And so modifying the study design to account for this difference for this unique population. And so lastly, with modifications based on these lessons learned, it is feasible and acceptable to conduct a fully powered randomized controlled trial, assessing the efficacy of Project Better's technology delivered intervention. That is all I have. So I can open it up for questions or comments. I think I don't know what time it is. I can't see the time. But.
Yeah. Thanks, Anna Beth. It was like a little journey through years of a project all the way to the end. So you held us on. So I'm gonna let people ask any questions about the project or about the findings or about lessons learned. Say, Anna Beth.
Hello, this is Deshonda Taylor. Thank you for your presentation. That was really awesome, and kudos to everyone who worked on it. And I know a lot of work went into it. My question was related to the randomization. So what did you all end up doing? Did you keep it kind of like as an intent to treat kind of way, or did you do more like per protocol? So which groups did you end up leaving the subjects in?
That's a good question. We left them in what they actually did, if that makes sense. So the people who were randomized to the brochure but then actually completed the intervention, they were put in the intervention group and vice versa. Does that answer your question?
Yes.
Yeah,
And
yeah.
then I guess since the results were similar between the two groups, I don't guess it would have, much of an effect, but did you think of anything else that it might have impacted or that randomization?
Because it was focused on feasibility and not on like a clinical health outcome, we don't think that it impacted things too much other than what us focusing on what we need to change for the actual like scale up randomized control trial. But it could, I think if we were looking at more of the health outcomes or opioid use disorder outcomes, that we would potentially see the bias there more so.
All right. Thank you so much.
Mm-hmm.
Anyone else have any other questions for Anna Beth? I'll go ahead and ask one. Other than kind of the lessons learned, Anna Beth, that you mentioned earlier, if you could go back and do something different, either with either with the intervention itself or how we design the study, what would you do?
Mm, I don't know, other than the like lessons learned that we have. I would say I would make the brochure less good. um, but that's not helpful for patients. It's good for them to have the information. I think um, making I do think that the intervention is quite long, and so I'm not surprised that the participants noted that. And um, PD was the best we had at the time, but I think shortening that and maybe piloting. So I guess maybe piloting the original intervention with more people, because we didn't have too many people in that like preliminary stage. So maybe piloting a little bit more to then hone the intervention, because it was very new to everyone. And yeah, so that maybe that's what I would change.
Those are good things. Or the other one I've thought about, which is very similar, is when we did the pre-testing, they just did one module at a time, which was purposeful and we had lots of reasons for that. But maybe doing that and then maybe a second phase of the whole thing together, because maybe we would have caught the length. I agree. Any other questions or comments?
I have a question. So these data are from before the individuals had given birth, correct? Okay, so I guess more of like a comment / question. Like, since a lot of these modules are aimed at the transition from like pregnancy to postpartum, do you think that there might be differences in the perceived efficacy score between the two interventions at that later follow-up time point?
Yes, that is quite possible. And that is some of the secondary. I think we did ask them in the postpartum assessment, and we also asked about like recovery outcomes and some parenting outcomes. And so those more like efficacy type questions are in the postpartum. But we wanted to ask before all of the things happen postpartum for this feasibility piece. But yes, for the efficacy trial, it would be asking postpartum, right, Dr. Martin? I assume, yeah.
Yeah. And that we thought about that too, Madison, when we were designing the study for even just like baseline things, because we were thinking, oh, well, if someone's had a pregnancy before, and if they had a pregnancy before and maybe they were on methadone or something their last pregnancy, then that definitely might impact even the perceived helpfulness, right? Because if you've already had a baby once with NOWS, you have a little bit of like something to work on in your brain, and you just pay attention to things differently after you've had some experience. So we do think that probably plays a big part of it. And that's even before the pregnancy even started. So there's a lot of factors at play.
Yeah.
I have a question about the brochure that you guys used as like the standard of care. If you were to expand this this study to include other clinics, like would you use their, I guess, standard brochures as the control at that other site, or would you continue to use like the OB Motivate like internal brochure at other sites?
Yeah, that's a good question. If we were going across multiple sites, and Dr. Martin, correct me if I'm wrong, but in order to standardize the study, we would use the same brochure across all of the sites. And then we would probably need information about like any kind of counseling. Like we would want to describe each of the study sites so we would see if there was any differences. But because lots of places do it differently, we would want the brochure to be standard across all of them.
Makes sense. Thank you.
You bring up a good point because the brochure has a lot of the content, right? And we did design it and it has all the things. So it does increase the risk of having a null effect. So, but in addition to what Anna Beth said, it would just be hard ethically not to do that too. Just knowing the dearth of preparation that these patients get if they're in a clinical environment that just isn't equipped with the knowledge and the training. So it would be hard not to do that, but it would be a risk then of maybe having more of a null effect of our intervention. Great. Well, thanks, Annabeth. That was wonderful. It was great to see all the results. Thank you again for presenting them tonight. And thank you everyone for your great questions and feedback. And so we will see everyone next month at the next lab meeting. As always, just reach out if you have any questions or interests, and we'll see everyone later. Thank you for joining. I know it's late. Bye.
Bye.